Okay, folks, it's 8 o'clock. Actually, it's 8:01. We've got three issues to look at this morning. The first one will be a hearing only on House Bill 409. And I noticed we've got 7 people signed up to speak. We don't have that much time on this hearing this morning. We'll look at it for about 20 minutes, and then we'll have to go on to the other 2 pieces of legislation. But like I said, this is hearing only on House Bill 409. So I'm going to turn it over to the sponsor of this bill, Chairman Allen Powell.
Thank you, Mr. Chairman, and I want to thank the chairman and the members of the committee for hearing this bill this morning so that they can sort of study it over. This isn't exactly in my wheelhouse of what I normally do, getting involved in the healthcare industry, but this ought to hit a soft spot because I've always been one of them who believes that registered nurses are the folks who keep the doctors from killing us. But it's quite simple. It's just a very...
Representative Newton, do you want to respond to that? Okay. Okay.
But it's it's a very simple bill. You should have a substitute if it got to you in time, but since it's for study to start with, you got plenty of time to do as y'all well pleased with it. But it addresses the issue, it gives the advanced practical registered nurses, gives them the authority working under a physician to write radiographic imaging tests, basically MRIs and CTs. They've got to be licensed for a minimum of 5 years, and they'd work strictly under the protocol of the physician. Be glad to answer any questions, but be careful because I don't know a whole lot about the medical profession except seems to me to be a good idea.
Well, okay, we got one on 18.
How many nurses can practice under one physician?
I think the amendment says 5, I'm believing it. That's what it was amended to.
Thank you.
Okay. Chairman Reinders.
Thank you, Mr. Chairman. To the chairman presenting, on line 18, and it just may be me so early, who have been licensed less than 5 years. You mean more?
For a minimum of 5 years. And I'm not sure if you've got the committee.
I'm looking at 7862S.
That is correct, as I see it. And that's maybe the language needs to be amended by this illustrious committee. But it's
well, I don't know about illustrious, but is the intent?
The intent is that they have been, that these nurses have been licensed for a minimum of 5 years.
Thank you.
Thank you.
Okay. I got a question. It's a little more theoretical, I guess. Every year, it seems like we get some kind of legislation like this, and I'm not picking on this group because I'm doing a broad range here, where we're continually being asked to increase the spectrum what someone can practice. So my question is, at what point will we get to where you have advanced practical nurses or whoever, whatever group, have received the ability through us to do everything a doctor can do with probably a third of the education?
Well, my understanding that this allows them to work under that protocol of the physician. Mm-hmm. And if a physician doesn't want to do it, then so be it. I tend to believe, I think in very simple terms, I think they probably do it already. If the doctors, usually they let them do prescriptive authority and different things, and they just basically put the doctor's name on it. But heavens forbid, that may not be something I'm supposed to say, but I'm not educated into the healthcare field.
I understand, I'm not either. And I guess one of the big issues I have, especially with young people, since they, from what I understand, and here again, I'm not a physician, but from what I understand, they take up radiation much faster than you and I do. And if you make a mistake, it's hard, I don't know if you can correct it. So I've just got issues of us continually increasing the scope of practice of various groups, and whether it's this particular area or wherever, I just have an issue with it.
Yes, sir.
Okay.
I understand.
Okay, we've got Representative Perkle.
Thank you, Mr. Chairman. And I'm not a lawyer, but as I read on lines 18 and 19, we're looking at the definition for a nurse protocol agreement and what it means, and it lists all the things that they can do in terms of their practice, except if you are a licensed practical advanced practice registered nurse with less than 5 years experience, you can only order radiographic imaging tests in life-threatening situations. So that's how I read that, Mr. Chairman and Mr. Chairman, that that the wording is correct on this legislation in terms of the intent that I think you're trying to get. These are a listing of the things that they can do, except if you have been this for less than 5 years, you only get to do the radiographic imaging tests in a life-threatening situation.
But also, if you look at lines 31 and 32, it says, or 30, 31 and 32, where it says, provided, however, that advanced practice registered nurse who has been licensed for less than 5 years may order radiographic imaging test in life-threatening situations. So.
Yes, sir.
Okay. Representative Bentley. Can I pick up the microphone on 2 down from you, because those, okay. Yes, ma'am.
Thank you, Mr. Chairman. Representative Powell, can you explain to me, without this legislation, what does this really mean? If this doesn't become law in the state of Georgia, what would happen? What would be the difference to what's currently going on to what your bill is proposing?
You know, not being an expert in this field, I'd say that probably it would just give credentials to those advanced practical registered nurses to do what they're probably already doing, that the physicians are probably giving the nod to do it anyway. But this just gives them that authority to do that, but they're still working on the direct protocol of the physician.
Thank you.
Thank you, ma'am. Dr. Newton.
Thank you, Mr. Chairman. Good morning, sir.
Good morning.
One of the things that we've been doing in the hospitals where I do work is recognizing, well, kind of like with the opioids, where we thought that it was right to treat pain and treat it aggressively. There would be no complications back in the late 90s and early 2000s. And then we found out later that it caused havoc in families across Georgia and the United States and other places. One of the things with these x-rays and CT scans becoming more common, fortunately the machines are getting less expensive, but a dental x-ray has a certain small x-ray or radiation exposure. A chest x-ray is about 20 times what a dental x-ray. A CT scan compared to chest x-ray of the abdomen can be 200 times more radiation. One of the concerns that I think has been brought up by both the FDA and others is a thing called radiation right, trying to watch as we're ordering more and more CT scans because of patient demand or because we're scared of lawsuits or whatever. I would just caution that something that's 100 to 200 times the radiation of a chest x-ray, if we increase those a lot, and believe me, in the emergency room, I see people with dozens of these studies. We don't know yet what's going to be 5 or 10 years down the road, and obviously we're worried about cancer risk, and you can't go back and unorder them 15 years later when we've exposed. I can tell you there's a lot of research going on into it now, and to dramatically expand, even though it might have been done in other states, to dramatically expand the number of CT scans. In particular, MRIs don't have the same danger, but they require some prior authorization. Even a physician can't order one of those by themselves without going through the people who are going to pay for it. So this is a stair step, and it kind of goes along the stair step of training. And so I would just caution that maybe we should go a little bit slowly on doing, exponentially increasing the number by tens of thousands of people who could order these without the same training.
I don't necessarily disagree with you, Doc, but at the end of the day, we're saying that they would work under the docs and under their protocol, and still everything that a doc is going to transfer down as far as authority, they'd better know that the folks that they're doing that they have confidence in what they're doing. Because I'm not sure, but I think it would probably affect their malpractice.
Thank you, sir. You got any more comments you want to make?
I have none. I just want to thank this committee for meeting at 8 o'clock in the morning, not necessarily for me, but if y'all take a good look at this and whatever the will of this committee is, I would certainly live to that. And like I said earlier, this is a little bit out of my wheelhouse, but as I understand this, the way this operates, it is only if a doctor wants those advanced practical registered nurses to have this type of authority. It's not like we're giving this to the nurses themselves. They've still got to work under the doctor.
All right. Very good.
Thank you,
sir.
Mr. Chairman, and thank committee members.
Okay, we've got several people who want to speak on this issue. Everybody who's signed up to speak in order to save time, would you come stand up on the side of the wall so that when one gets finished, the next one can just start? I've got Desiree. I'm going to murder some of these names, I know. Everybody who's going to speak on 409. Okay, now, we've got about 10 minutes left. So don't be redundant. Don't say something everybody else has already said, but you've got about a minute and a half each. So make it succinct and right to the point. And when you get up to the microphone, identify who you are and who you represent. Thank you.
Thank you, Chair Powell, and for co-sponsoring this bill, and also for Chair Smith for hearing us today. My name is Dr. Desiree Clement. I'm a professor at a local university. I also am the co-director of Georgia Coalition of APRNs. I am here to testify on behalf of Georgia Coalition of APRNs and APRNs around the state. And this is to House Bill 409. First off, this bill does only one thing. It allows APRNs the ability to order advanced imaging such as CT scans and MRIs in routine situations. Currently, we're already doing it in life-threatening emergencies. I'm going to go over a few things in a minute, but I just wanted to say we are the only state left in the country who has a restriction on radiological imaging. The only one left. And that's pretty powerful. Everyone else, this is part of their national certification, and all the states besides Georgia and even U.S. territories do not have a restriction on APRN ordering of radiological imaging. We already can order, and we're trained to order, and we have a national certification that prepares us to already order ultrasounds, x-rays, what we call more basic imaging. We already can order life-threatening advanced imaging only in life-threatening emergencies under our nurse protocol agreement. We're working under our physicians for that. So just to remind you of that, I just want to do real quickly is to just dispel a couple of myths. It is not true that APRNs over-order and over-radiate their patients. There have been no studies shown to our awareness or that we could find that support this data. Again, 49 other states obviously know this. APRN is already seeing the majority of the time their patients. The physician is not seeing the patient, even though we know where our scope lies and we work under our nurse protocol agreements with our physicians. Physicians already rely on APRNs to determine when the need to order. We are trained to be able to do so. NPs working in regional centers may need to order MRIs daily, such as in neuro areas, where they're doing that. Or, more importantly, national guidelines that support it. Like I'm in women's health, and if a woman has been identified as high risk with breast cancer, the new guidelines state we need to yearly order a mammogram and an MRI for a breast. So therefore, keeping these guidelines could delay treatment and cause more increased costs when we already have an access to increase issue here with care in Georgia, and our statistics are poor in health care. It's very important in rural areas where physicians may be miles away and an APRN is on site working with their nurse protocol agreement. So this drastically can continue affecting and impacting our rural areas. Finally, we are qualified to do so, again, stated by our training and national certification. And we also, there's not been any support to prove that we increase costs, we affect quality outcomes. In insurance, remember, as Dr. Newton said there, it is run just like with physicians. It has to be approved, especially during routine, approved by insurance. So if we were doing this, wouldn't the insurance companies already be making this aware to our physicians? And we also work under our own malpractice. If our practice does not extend malpractice, then what happens is we have to go get our own malpractice. And again, we work under those nurse protocol agreements. Just to remind you as I move on, insurance has to approve this.
We're limited to about a minute and a half, so.
Okay. And that just no significant research to date supports the claims that APRNs should not be doing this. Thank you very much, and we hope that you support our bill moving forward.
Thank you. Next.
Good morning. I am Suzanne Stabler. I am a doctorally prepared neonatal nurse practitioner and a clinical professor here in Atlanta, and currently my clinical practice is at Grady. And so I'd like to give the committee members and Chairman Smith and Chairman Powell a different perspective this morning on behalf of my colleague, Dr. Carolyn Clevenger, who runs the only nurse-led primary care dementia clinic in the state. And so for dementia patients, especially if they are in a long-term care facility or assisted living, if they should suffer a fall, a visit to the emergency department is quite distressful for them and for the emergency staff. And so being able to, as a nurse practitioner in this clinic, being able to order a CT directly and sending those patients with their caregivers directly to radiology and not having to go through an emergency room admission and that whole process not only increases their access to care and gives the provider a quicker diagnosis, but it decreases the stress with the dementia patients. There is, in the treatment of Alzheimer's disease, there is now a new medication called gantenerumab, which is a new monoclonal antibody. And so the memory care clinic here in Atlanta is actually going to be a part of the phase 3 trials for that new medication, which has shown great promise in stopping the progression of Alzheimer's disease. But it will require MRIs to be ordered every other month during the first year of treatment to monitor for some very serious side effects such as cerebral edema and cerebral hemorrhage. And so the patients in this nurse-run clinic where these patients are getting their primary care and their dementia care will be significantly impacted by not being able in a very quick and timely manner to order those tests and get those results on their patients so they know what to do with that therapy. So with those patients in mind, we would like to ask the committee to favorably pass this bill out of committee. Thank you, gentlemen.
Thank you, ma'am. Next.
Thank you again for time to speak. My name is Troy Heidish. I teach at a university and have been a nurse practitioner for almost 20 years, working both in family practice and emergency departments. I will say that the education requirements on nurse practitioners are in depth. They are required to have a 4-year degree before they can get into an advanced practice educational model. That typically takes anywhere from 2 to 4 years, sometimes exiting with a master's degree, sometimes exiting with a doctoral degree. In my teaching of those particular students, there is a heavy emphasis on being a good diagnostician. We spend a lot of time making sure that they understand what to look for, what to order, and particularly not over-ordering or over-testing these students. There's a great deal of emphasis on making sure that not only are we working toward the correct diagnosis, but that we are not over-ordering what we do. My main research focus has been on clinician shortages and what that means to healthcare outcomes. Data has shown that not only do we have physician shortages, but even with the nurse practitioners that we have, getting them working in these environments still does not give us enough clinicians to handle both the millennial generation that is only a few million behind the baby boomer generation, so we are in great need for them to be out there, especially in rural areas. And what we have with these issues like this radiology restriction is that nurse practitioners that we educate here in Georgia decide, you know, I can go to 49 other states and I can do more to help my patients without seeing a delay in the care that they get. So I would ask that you support the bill for moving forwards for an ability to order routine x-rays by nurse practitioners. Thank you.
Very good, thank you. I see no questions. Next. Oh, hold on one second. Chairman Reinders.
Thank you, Mr. Chairman. I always love they'll go elsewhere. What is the percentage of shortage currently in Georgia for nurse practitioners?
I will say that we are currently, I believe it's 30,000, maybe?
So we're short 30,000.
Yeah. So well, I should say that's clinicians. That's both physicians and nurse practitioners.
No, I want to know nurse practitioners because you said they go to other states.
They do. They do go to other
Yeah.
states,
So
and I've got.
can you give me the number and site? You don't have to do it now, obviously. But if you'll give me the source to show us just how short we are on those since they're leaving.
Sure, yeah.
Thank you.
Mm-hmm. Thank you. Any other questions?
No other questions. Thank you,
Okay.
sir. Becky Rouse.
Thank you, Mr. Chairman, members of the committee. Good morning. I'm Becky Riles. I represent Management Services Network. They are a billing practice company for medical groups, including radiology. They also administer the Georgia Radiological Society. So I stand before you today to let you know that radiologists oppose this bill. And think about that. It's not the typical scope of practice fight that we know very well under the Gold Dome. The radiologists will read whatever study is ordered. Their concern are really 3 parts. 1, quality, 2, safety, and 3rd, cost. The American College of Radiology has started in the last 5 years an Image Gently, Image Wisely, which is a focus on physicians and their colleagues about ordering the appropriate test at the right time and not ordering tests that are not necessary for the 3 reasons that I stated. For example, advanced diagnostic studies are called that for a reason. They're not a screening tool. Typically, a practitioner should know or have an idea of what they're looking for. And those of you who are trained in the medical field, this goes back to your epidemiology and research design. Your specificity tests and your tests for sensitivity. You're either trying to rule something out or rule something in. So in the essence of time and out of respect, Mr. Chairman, to your request, I will follow and just sum it up with these 3 points, and also to raise the concern that we have about the report. So the radiologist sends the report of the study back to the ordering provider. And if that provider does not know exactly what to do with that report, then it could endanger the patient tremendously. Finally, as it relates to the numbers in the state, when you look at the data as far as providers, physicians, mid-levels, other healthcare providers. Unfortunately, they're not in rural areas. So this bill would not address and do anything to increase access to healthcare in rural Georgia, which we are all very concerned about. Thank you, Mr. Chairman, members of the committee.
You know, the reason I had them stand on the wall like that is because that's what we have to do every morning before we go to rules, and we want to get them to have the same kind of experience. Oh, yeah, hold on, okay. Becky, you want to come back?
While she's walking up, just to save time, you said that they're opposed to this. Are they opposed to this in the other 49 states who allow it? And if they are, can you give us some data that shows that there have been problems with it?
So I'm speaking for the Georgia Radiological Society, but there are certainly concerns across the states. And while other states do have some restrictions on how and when APRNs can order these studies, and the American College of Radiology is continuing to educate not only radiologists but other physicians about the importance of ordering the appropriate test. So an MRI, CT, it's a $1,500 study. And if you order the wrong one, then you've just, put the patient through that study and at a cost that was unnecessary. So it is very important to know which is the appropriate study. Oftentimes, a radiologist will pick up the phone and call the ordering provider and say, what is it that you're looking for, and why'd you order an MRI? And then after that conversation, the radiologist might say, well, a CT would be more appropriate.
I'd just like data on problems that it's created in the other 49 states if we're going to compare Georgia to them.
Sure. We'll be glad to do so.
Thank you, sir. Yes, I think that's the last question. Thank you.
Thank you, Mr. Chairman, and I'm happy to continue watching you all stand on the wall and at this podium in the future.
My name is Bethany Scherer. I work for the Medical Association of Georgia. We represent about 8,000 physicians across the state in all different specialties and all different practice settings. We just rise to oppose this legislation, and I'll echo everything that our colleague Becky has mentioned. And we just really want to make sure that patients are getting access to high quality care and keep our patients safe.
Any questions from any committee members? Okay, very good. Thank you.
Good morning, Chairman Smith. Thank you for the opportunity to be here and the other members of the committee. My name is Dr. Michelle Nelson. I am the state president of the United Advanced Practice Registered Nurses of Georgia, and I'm also the co-director of the Coalition of Advanced Practice Nurses. I wanted to actually address some of the things that were asked earlier, and I'm very happy for the question that you just asked. In terms of wanting to know if there were problems in the other states. I am a researcher at a large university here in Atlanta, and in preparation for this committee meeting, I scoured the internet. I did my homework. I have a PhD from Emory. I'm well trained in research. And the reason why there is no response to that is because there is no evidence in the other states that show that advanced practice nurses are causing any increase in cost or that they are over-radiating patients, which are some of the myths that were brought to me. Advanced practice nurses, I represent 13,000 of them in this state. And as an educator myself, I can say, I teach in a family nurse practitioner program. We have a very robust set of programs. The students that we produced are competent, they are confident, they work with physicians under a practice agreement. We have not gotten feedback in terms of clear data that shows that advanced practice nurses are a danger on any level when it comes to radiology. As it was said before, we are the only set of advanced practice nurses, to define it even more, the only set of advanced practice providers in the only state that does not allow advanced practice nurses to be able to order radiological exams. Another one of your colleagues also asked earlier, what does this exactly mean? Let's just break it down to what this means. This, without us being able to directly order advanced imaging for our clients, a lot of times it can result in a delay in care because we now have to seek a physician to sign off on something that we are trained and we are qualified and we are educated to do. If we have been given the authority to do this in emergency situations, well, most certainly we are also qualified to do it under any other circumstance. This only serves to bolster the citizens of ours in our great state of Georgia, especially in the rural areas where they need care the most. Another question was asked regarding, well, how many APRNs will go into the rural area? The reason why there is not so many APRNs in rural areas is because there aren't enough physicians in those rural areas to oversee what it is that we do. But I work with many of them, and I also have many members of my organization who are from those rural areas and would like to be able to go back to them to work in the communities that they're from and be able to provide care. I want to thank you so much for the time to be able to address everyone, and I'd be happy to take questions. I see one here in the front.
You have a question,
Yes,
Chairman
please.
Reinders.
Thank you so much. I'm confused. The reason why we don't have more advanced practice nurses in the rural areas is because we don't have enough physicians.
Because of the ratios.
Right.
So we have a
So if we
ratio,
passed this, more physicians would come.
not necessarily.
That's
I
my
don't
point.
oversee.
That's
I
kind of my
don't-
point. It's a chicken and egg thing. You just said, and I appreciate all the research you've
Okay.
done and being an expert on research, but you did say that if we pass the, I mean, you said that more advanced nurse practitioners would be in rural areas if we had more doctors. And I don't see, or physicians, I don't see where this gets us more physicians. So we're in the same situation.
Thank you so much for your comment, but this is being taken out of context. The reason why I said that, why we don't have enough or enough time in order to be able to do these in rural areas is because of our ratios, but that is a completely different issue than what we're discussing today. What I'm discussing today is the ability for advanced practice nurses to be able to order these imaging tests, especially in the rural areas where there's a problem with access to care. So I can't speak to
Well,
why
you did-
there are doctors
Mr.
or not
Chairman-
enough of them in
Mr.
the rural
Chairman, but
area.
you did speak to it, and I don't want to be, you said
Yes?
the reason why we don't have more advanced practitioner nurses is because we don't have enough physicians. That's what your testimony was.
That is correct.
And I'm just asking, if we pass this, how does this get more physicians?
This is not meant to increase the numbers of physicians.
Okay, thank
This
you.
bill is meant to increase access to care.
Yeah, and I was talking about
for-
access in rural areas for advanced practitioners. If they're not coming because of physicians, passing this, unless we get physicians, won't matter.
No, that's not what I said.
Okay,
And I don't
thank
want
you.
to, I most certainly would love to be able to clarify my statement, and I don't want it to be taken out of context. The reason why we're not able to do this is because we don't have the authority to do it. So in rural areas where there are not enough providers, whether they be physicians, whether they be advanced practice nurses, and most certainly we need more of both, what we need to have is removal of a restriction that is going to increase or that's going to decrease access to care. What this is doing right now is increasing the time in which our citizens are getting services. By removing this restriction, it allows advanced practice nurses who are already trained and who are already educated to be able to do these services, especially in other states. This allows them to give direct care to the patients without something in the middle as a hindrance. I hope that I've answered your question.
Okay, I think time's out. We've got one more
Thank you.
person who needs to speak. And then we'll go on to House Bill, or substitute House Bill 89.
Thank you, Chairman. Thank you for giving me the opportunity to speak. My name is Erin Hernandez, and I am representing our National Organization for Pediatric Nurse Practitioners. I am a pediatric nurse practitioner, and I have worked for 22 years in a pediatric emergency room. And I would just like to discuss the myth about pediatric nurse practitioners ordering more x-rays or causing harm because of the radiation to pediatric patients. And like Michelle and my other colleagues testified, as pediatric nurse practitioners are educated, we're very aware of the risk of radiation. We don't jump to CT scans of head injuries. We work under not only our supervising agreement with our physicians, but under national clinical practice guidelines. We rarely do head CTs for children with or sports injuries, head injuries anymore. So I just wanted to assure you that that would not be the case with the pediatric practitioners. We are educated, we're trained, we are very aware of the risk of radiations, and I do hope you support this bill. Thank you.
Okay, thank you. I know there was a bill, Senate Bill 109 that passed out yesterday, I think. I know it passed out of committee yesterday or the day before. So this probably won't be the last time we get an opportunity to take a look at this issue. Now, a couple of when I go home today, I'm probably going to have my head skint because my oldest daughter is a neonatal nurse practitioner. So, and the comment about the 49 states, maybe they're doing it wrong and we're doing it right. So, I don't like those kind of comments because it really means nothing to individual states on any, as far as I'm concerned, on particular any issue. Okay, House Bill, substitute to House Bill 89, Chairman Chuck Martin. And you should be familiar with this language.
Yes, sir. Mr. Chairman, if it serves the committee, I'm working today from substitute for House Bill 89, LC 337858S. And as Chairman Smith mentioned to the members of the committee, thank you for hearing us, or hearing me for a few minutes this morning on this measure. I will go into the detail of the description of the Integrated Ambulatory Surgery Center that's on lines 11 through 25 of the bill. I could go through that. Several points, Mr. Chairman, although I think you and I agree that that is the language that this committee has seen and vetted in Chairman Hatchett's bill. So would you like me to go through that, Mr. Chairman?
Yes, please go through a little of it so
okay.
Kind of a refresher.
Yes, sir. I'll just refresh it. This is not just an ambulatory surgery center where they wish to do surgeries. The idea of this facility is just what it says, an integrated facility geared toward not just doing the surgeries, but doing training for the surgeries, and then also providing sports medicine facilities and fields to train people that work with youth. We have a tremendous problem in this country, and we've passed over the last couple of years here various things for athletic trainers to have our high school athletes and our actually pre-high school athletes, the people that work with them, learn to recognize, everything from heat exhaustion to, being overworked at practice. There are rules that go in place, even in the college athletics now, about how many hours one can be on the field. So this facility wishes to integrate the medicine that goes with the surgical or orthopedic surgery and the diagnostic imaging to a community education program that will go back into the state of Georgia. So while this may be a facility located in Alpharetta, north of Atlanta here, the idea that Dr. Andrews has is to spread the knowledge that has been gained by him and people that have worked with him for about 40 years in doing surgeries, but also the people that work with them into preventing these types of injuries. So what this facility is required is not just the surgery centers, but just real quickly, additional sports training facilities and fields, medical educational facilities and programs for physicians and healthcare professionals, medical research program, ancillary services which include physical and diagnostic imaging, community education for student athletic programs,
And it also will deal, if it deals with kids, it will participate in our Peach Care for Kids program. It will not turn away people that need care. It will have an economic impact of no less than $25 million from its construction and ongoing operation. And probably most importantly, on the back, as it asks for the exemption, it will do at least 5% of its adjusted gross revenue in indigent care and do all the reporting that's required by any facility. I might also add, Mr. Chairman, that this has been approved for its CON previously, going back to September 2015, and it's been a bit of a seesaw that it was approved, then it was overturned, then it was reinstated by the commissioner, then it was overturned. So it's clearly something that is a close call, even if you will, and it's when it's being looked at just in the surgical facility. So it's my opinion, and I would ask the committee to look at it when you throw its overall contribution to the community and to the greater state of Georgia. I think it's just a facility that will be good for our state, be good for our citizens, and will integrate with our programs through high school and youth activities. Stand for any questions, Mr. Chairman.
Does this still include the 400,000 square feet?
That was not in the discussion that, or excuse me, that was not in your description. It was in our original bill, but it was not in the description you asked us to match, so we did not include it here.
Okay, well, it's in 198. Am I correct?
This is the language that's
Okay.
in 198.
Same language that you have in 198.
Yes, sir.
Chairman Reinders.
First of all, thank you, Mr. Chairman, and thank you, Mr. Chairman, for presenting the bill. To you, Mr. Chairman, if I may, going back to our colleague who talked about the scrubbing at our last meeting, do you expect, is it your plan that different points within 198 will be brought to us separately as individual bills?
What I anticipate is that if 198 passes on its own, this will be mute.
And the reason I ask that is because I don't know if we need to be prepared to scrub each one of these, or if there's going to be a total scrubbing done.
Yeah. But if 198 passes in the version that will be presented this morning, which includes this exact same language, then no, this bill will not be brought up for a vote.
All right. If I may continue to the author
Yes,
of the
sir.
bill, Chairman Martin, you said will not turn any people away who need care. You stand by that statement?
That's what has been related to me by by Dr. Andrews in a letter, that they intend to treat people that need care.
Then
obviously, Chairman, I don't want to stand. I mean, I want to be honest. Obviously, they cannot treat every person that walks in.
Well,
They
that's
don't
why I'm
have the
questioning that
capacity
statement,
to
because
do
I've been
that.
more than happy to make an amendment to that effect.
Well, I mean, obviously, they would do that to the level the facility has the capacity, but the capacity of the facility is limited. The point is, they would not. There's been a conversation and there's actually some ads you may see on the radio about the greater conversation that this committee's had about this facility cherry picking, or facilities in general cherry picking clients. My point in that statement, and to be clear, and thank you for allowing me to clarify it, is they do not and would not do that. Certainly, I don't want to stand here before the committee and say they could treat every indigent patient in the state of Georgia, nor can any hospital that exists today or would in the future.
And if I may continue with that thought process, and I thank you for the clarification. We in 198 have talked about the potential, and I'm going from memory, so give me a little wiggle room and correct me if I'm wrong, about the cleansing or the pay mix as it relates to Grady, and a certain threshold there. And I'm wondering why we wouldn't ask others, including this one, not to look at some kind of payer mix threshold as well. That's a 75%, if my memory serves me right, as it relates to Grady. So, and I get you can't serve everybody, but as I read this, what did I see, 5%?
Yeah, my understanding is in the current language in the bill, there was a 2-year, it said you would have a 2-year rolling average and I'm going to ask the attorney to help me there. Since that is not referred to in this standalone bill, it's defined in the larger bill. What our intent was, the current 2-year rolling average is right at 7%. Private hospitals are 2% less than that, so that's how we came up with the 5%. So that is to, again, mimic Chairman Smith's language to get the same language in the bill that you would have in 198, but since the rolling average is not defined in the standalone bill, we couldn't use that language exactly.
And finally, my point would be there's a big difference between 5% and 75% as it relates to being able to serve.
What you have to understand is that private hospitals pay taxes.
I understand that.
Nonprofits don't. So.
Right, I understand. Thank you.
So if I may, I know you're in the interest of time, but to be clear that I followed your instruction, Mr. Chairman, we couldn't use the rolling average because that's not defined in the bill, but the attorney advised me that the current rolling average as it was defined was about 7, so 5 was about where we needed to be for for-profit hospitals. We tried to match what the chair asked.
Then just a couple technical questions. Why is the $25 million relevant? If somebody wanted to come to Valdosta and open one up at $15 million, tell me why that's relevant.
It's relevant because Chairman Smith asked me to have the definition the same as in 198, Chairman Reinders.
Okay. Well, again,
you might want to direct your question.
Chairman Smith, now we're back into my scrubbing this one or my scrubbing that one. Thank you.
Okay. Chairman Cooper.
Okay. First of all, if I might ask, Chairman Reinders, what line were you talking about in treating all patients?
No, that was the chairman's quote,
okay.
And I just wanted to see how they were, where that is in the language.
All right, Chairman Warren, let me clarify this. Are we talking about that they will take all orthopedic? I mean, these are going to be
I just quoted him exactly. I don't know what he meant by that.
Well, I'm trying to get a clarification. Okay, this facility is going to be staffed with highly trained sports orthopedic physicians. If you treat all patients, I sure don't want one of them treating me if I have a brain injury. So are we saying they will treat all orthopedic sports and people that come with orthopedic problems?
Well, Madam Chair, as somebody joked earlier that they weren't a lawyer. I'm not a doctor, and I didn't stay at the Holiday Inn last night, but I don't think any medical professional is going to treat anyone outside their area of expertise. My statement, and let me be clear, it was the relative toward this facility only taking paying patients. Chairman Reinders makes a good point when I said they would take all indigent care patients. I didn't mean every one. I meant if an indigent care patient came and needed the care that this facility provides, that they would not turn them away because of their inability to pay.
Okay, there is so much discussion about this. Can you please, going forward, be specific that they are not going to turn away any indigent orthopedic sports or or any patient that has the needed care from the specialty that they offer, the specialties?
Well, yes, ma'am. I mean, and I apologize again. I'm not a medical professional, but I apologize. I thought that would go without saying that a medical professional would not treat someone if they were not otherwise qualified to do so. I apologize to the chair.
Okay. All right. Chairman Nix.
Thank you, Chairman. This sounds a lot like the Cancer Treatment Centers of America when they came in back several years ago. And my question is this everything they want, or will they be back 2 years from now, 3 years from now, wanting something else and spending millions and millions of dollars to lobby it?
Mr. Chairman, I don't have any view into the future any more than you do. I do know this, that they have a definition under which they have to work. I think if they are providing services for the citizens of the state of Georgia and they're making it a better place to live, and they or anyone else chooses to come and exercise their right to ask this body or any other body of competent jurisdiction to do things to allow them to service Georgians, they would have that right, but I can't look into the future.
Chairman Spirey.
I just want to follow up on Chairman Reinders and Chairman Cooper's comment, reference the indigent and uncompensated indigent service cherry picking, so to speak. What, line 32 on page 2, doesn't that clarify that? I mean, explain that to us on line 32.
Yes, sir. I mean, that's what a facility defined as such, and I'll read line 32 as Chairman Samari asked, provides for uncompensated indigent and charity care in the amount equal to or greater than 5% of the adjusted gross revenue.
Isn't that telling you what they're going to do on indigent care and uncompensated cases?
Yes, sir. It would tell you that they were going to, help people, an amount equal to or greater than 5% of their revenue.
Thank you.
Thank you, sir. Ms. Bentley. Use the next one to your right. Thank you.
Thank you, Mr. Chairman. This question is really for you. Can you kind of reiterate what you meant? You stated that to Chairman Rinder, nonprofit. Did I understand you wish hospitals didn't pay taxes? Can you repeat that, please?
Your nonprofit hospitals do not pay taxes. Your for-profit hospitals do, and that's the reason you have the spread between for your for-profits they have to do 7%. Your nonprofits have to do. Your for-profits have to do 5% because they pay taxes, and that 2% supposedly makes up the difference between the 5% and what they pay in taxes. Your nonprofits do not pay taxes. So that's the reason for nonprofits you're at 7.
Okay, thank you.
Dr. Newton.
Thank you, Mr. Chairman. Appreciate the bill. Just looking on the sheet from the Legacy Sport Institute.
Yes, sir.
It does have, there is a 501c3 section is that for the training, but the facility itself is a for-profit endeavor, isn't it?
That's my understanding, sir, but they will probably, I think the foundation you look at is to do outreach and training for other.
Teaching and training, okay.
Yes,
so
sir.
it will be paying taxes, so if people come from other surrounding states as a place to come to our state to have health care done, that would go into Georgia, they would pay Georgia taxes on that, is that right?
That is my understanding, sir, and to that end, my understanding also is that they would, do training of physicians there. I believe, am I saying that right? Is that residencies or clinicals? Those would be offered as well, and those folks could go back and practice after that in various Georgia medical facilities.
Thank you. I just wanted to.
Okay, that looks like all the questions. I think the policy or procedure now is for a motion to either do pass or whatever. Got a motion, have a second? Okay, all in favor say aye. All opposed, like sign. Okay, hand raised. All in favor? All right, 1, 2, 3, 4, 5, 6. Is that 7? Okay, all opposed? Motion passed.
Thank you, Mr. Chairman. Thank you to the members of the committee.
Okay, Chairman. The next bill that we'll be looking at, they're handing out the version of the new version of House Bill 198. It's substitute to 198. If you'll notice, the original bill had either 81 or 82 pages, 83 pages, and this one's got 31 or 30 and a half pages. Shouldn't take near as long to go over this one as it did the last one. Okay. Chairman Hatchett, does everyone have a copy of the bill? Do you have a copy? Okay. Okay, let him present the bill and then we'll ask. This is a substitute to 198. Yes. Okay, Chairman Hatchett.
Thank you, Mr. Chairman. If it is the pleasure of you and the committee, I would love to sit right here and present this bill.
Go ahead.
Okay. First off, I want to thank the members of the committee, the members that I've talked to about this bill over the time, for your time, your research, your hard deliberation over what this bill has contained over the past several weeks. And I want to thank you for the support that you've given me up to this point, and I hope that continues. That being said, I do firmly believe that what we passed out of here earlier this week was a piece of legislation that would have saved people money in health care, patients. It would have driven costs down. It would have made health care more accessible by having more lower cost facilities built and available. I also want to say that I will continue to make a deliberate effort to effect change in our current CON regime. The sky is not falling. Chicken Little may or may not be in existence. Fortunately or unfortunately, we're not the only chamber in this building. And the other chamber failed to take any action on CON replacement. So this bill, I'm going to call a CON modernization. The sky has not fallen. You guys across the back of the wall, they're smiling. What the bill does, it keeps CON in existence with a few changes, exemptions, exclusions, and I will go over those with you at this time. On line 36, we will increase the level of exemption for construction of new projects to $10 million. The exclusion on the next, on line 37, of purchasing new equipment and other things you can read, to $4 million. Line 47 begins the discussion of freestanding emergency departments as long as they are hospital owned, and they must take Medicaid. And if you're an emergency department, yes, you got to be open 24/7. Starting on line 74, we will allow cardiology ASCs to exist. It is my understanding, and I firmly believe, that the only reason they do not exist now is because they weren't at the table years ago when that was done. And that will allow less expensive treatment in cardiology. Page 6, line 173, begins the discussion of CTCA. They will be allowed to become a hospital, regular hospital, meeting all the indigent care requirements that they have if they choose to change, and the indigent care requirements subject to the rest of this bill. All right, line 210. This begins the discussion on indigent care and the new requirements that we had in the previous bill. What we're going to do is delay the penalty that was outlined in the previous bill to July 1st, 2021, but effective June 30th of 2019, you will begin to report your indigent care also in the method that we are laying out based on charges of based on the Medicare times 1.5, the base allowable rate of Medicare times 1.5. You will continue to perform it as you do now and report it as you do now on the hospital survey. But yes, we will be asking for additional work to do this so that in 2021 we can know where we are with the new percentages of indigent care and see if we need to address this section before that so that we're not causing the sky to fall. Section 1.5 on that page goes through that same portion about the indigent care and what we're doing, what we did in the previous bill. All that goes on also page 8. Okay, page 9 in discussion on the CTCA portion. If they are allowed to become a hospital and CON remains in existence, then their inventory beds, all of the equipment would then be part of the CON inventory that is used by region to allow for growth by other hospitals. So to protect the hospitals that are near them and in their area of service, that inventory would not be counted in the survey to not cause a false reporting in the future for the other hospitals around them. Line 313. Although we are continuing with the certificate of need requirements, this provision will allow for only those existing parties in a 35-mile radius to object to a proposed project. So somebody in Blue Ridge can't object to a facility being done in Savannah unless they own a facility in Savannah. Line 440, page 13. Continuing care retirement communities. What these line outs or deletions would do would be to allow them to accept will allow the CCRCs that do not accept Medicaid patients to allow patients to come to them at any time. Now you have to come before you are non-ambulatory. Line 612 allows for an exemption to CON for public or private psychiatric hospitals, mental health, substance abuse facilities. And line 614. Oh, I guess mine. This page 18. Is that 1612? I just can't.
612.
Oh, 612. Allows for exemption of mental health. Line 614 allows for the exemption for legacy sports. Section 2 is the same transparency provisions that were in the previous bill. Section 3, which starts on page 24, are the changes that we made as far as the rural hospital tax credit. The only difference there is that the reason, one of the main reasons we were increasing it to 100 million was to protect our rural health care facilities, rural hospitals. And since we're not changing CON, we're going to keep the threshold at $60 million. And the other change in Section 4, this bill will become effective upon the governor's signature. And I believe that are all the changes that have been made.
You ready for questions? Yes, sir. Chairman Nix.
Thank you, Mr. Chairman. Mr. Chairman, I appreciate this. I can vote for this bill. I appreciate the fact that y'all have stepped over the line and looked at some of the concerns. Thank you very much.
Thank you. Thank you very much.
Okay, those people who are sitting back there on desk 74 and 75, would y'all stop mashing y'all's button? Okay, number 20, Chairman Parrish.
Would you mention that again? I think it says on page 24 about the limit on the tax exemption for the donations.
Can you tell me what line you're talking
Well, when you went through there, I was trying to follow you as you were talking about you're going to leave the cap at 60 million.
Yes.
Was that over there on page 24? Is that where you said?
I don't know where.
What's that?
28.
Page 28.
Oh, okay. But, you know, there was some interest in moving that up to the 100 because it had been oversubscribed before, but I understand now that that's not a problem. Is that correct? That you think the 60 will be sufficient to?
I know that in 2017, the fund was fully, the tax credit was fully funded, or however the proper terminology is there. I do not have any numbers, the specific numbers for, hold on, I got information about that this morning. I don't want to misspeak, hold on.
But this just leaves it at the 60, like we wrote.
This leaves it at 60. 2017 was a little over 8 million. 2018, with the full 60 million was funded. And of course, it's still open for 2019. So there was no number given to me as to where it is at this point.
Representative Fry.
Thank you, Mr. Chair. Chairman Hudson, thanks so much for all your hard work on this. I appreciate you making some changes. We're moving in the right direction. So thanks for that. I wasn't able to follow you. I was trying to make notes and keep up on page 13, line 444, talking about the Medicaid patients. Could you explain that to me again real quick? The strikeouts that they're allowing.
CCRCs, there are a few that were in existence early on that do have some Medicaid patients and do take Medicaid patients. But by and large, they do not take Medicaid patients. This would only apply, this exclusion from the things that are marked out would only apply to those facilities that do not take Medicaid. These facilities exist for those that are not on Medicaid or and do you understand what the facilities are?
Yeah, I got you. That answers. Thank you so much, and thanks for your work on this. And I look forward to and some more massaging it to get it where we can all support.
I'm sure this will continue for days.
Thank you, sir.
Thank you.
Dean Smyrie.
Mr. Chairman, I want to thank you, President Hatchett, for working and talking and discussing. And I've had a lot of discussion with Chairman Smith and with you, and I think we've come a long, long way. This is an issue, I think, I remember when we created as a policy position on CON years ago, and now to come to this point, I know everything always requires adjustments. And I just want to publicly thank you. I've sat with you and I've talked to you and I've texted with you. And that's how the political process works.
Thank you.
So I still think we need some improvements. But that's what the political process is all about, give and take. And I just want to say that publicly, and I just want to thank you publicly.
These kind of issues are never easy, and if anybody wants to know how this kind of bill works, or it's a process, and unless you understand that, you got a long way to go. Ms. Bentley?
Thank you, Mr. Chairman. I too just say to Representative Hatchett, Chairman Hatchett, for your good work on this, and I'm really comfortable with this legislation, and I do look forward to voting yes for it. So thank you for your work.
Thank you.
All right. You know, we may make session on time. Okay. All right. The bill, yes, Chairman Reinders.
Thank you, Mr. Chairman, and thank you, Chairman Hatchett. Just a couple things that I don't know, and I apologize for. Line 284 on the destination center says may convert to a hospital. Do they actually have plans? It says may. Are they going to do that? I don't know.
So say that one more time.
Line 284. I always look for the mays and the shells.
It's a may. It is.
Yeah, right. I know it's a may, but do they plan on it? Do we know that?
I think they do plan on converting.
Okay,
yes.
thank you. And on the next page, on page 10, starting on line 313, no party may oppose, only because I've seen this. I think there are rules in place as it relates to what's called legal standing. And what keeps, I'm concerned with someone not having legal standing or may have the legal standing and being used as a surrogate by someone or an entity that doesn't have legal standing, because I've seen that movie. Would this prevent that? And the hypothetically would be an Emory, which is 150 miles away, goes and tells, we are hospitals in Waycross, Georgia, can you oppose this for us because we don't have the legal standing? And it gets manipulated that way, because I've seen that, and I just hope that as we move forward, that's something that we will take into consideration. And then finally, on page 18, which was one of the reasons, the 5% that we just talked about, I'm sure it's somewhere else in the bill as it relates to the legacy. Did I miss that? Is that in this part?
It is not. They would fall under the rule. They would fall under the rules that come into play here. Yes, if they become in existence before July 1st, 2021, they would be at the 5%.
Okay, and if they don't before then, they'd be at what percent?
Whatever we establish whatever the rolling average is, less 3%, with a floor of 1%.
Are you guaranteeing us a minimum of 5%?
No, not after
Okay.
2021.
Thank you.
Okay.
Okay. You want to push your button there, ma'am? There you
I had
go.
a question about the 35-mile radius. If a large hospital has a facility in other counties, does that count? Is it the 35 mile from the home base?
It would be 35 miles from the facility that is requesting where that address is where the facility will be, the new facility, or where they are.
But, you know, some hospitals have as many as 2, 3, 4, 5, 6, 7, 20 different counties. Is patient centers in 20 different counties? Is that 35 miles from all those 20 counties?
Yes.
Well, that would take up a big portion of the state that you could not have any competition. To post CON, you know.
Well, only if you have, if you have a facility that is in that 35-mile radius, then you can oppose it. And if they are an entity
But if it's not a if it's a facility, but does it have to be a CON approved facility or just a facility?
Well, they'll all be CON approved facilities at this point. No, I mean, that's what this is in.
I don't know what a hospital outpatient center is.
I'm not looking at it. What line was that in? You said it.
It's just a question regarding the 35 miles. I don't know what a hospital outpatient is. It was on a handout that we saw.
What line is that? Y'all, I'm trying to help me.
And that was a 35-mile radius. That if it was just a facility, or does it have to be the person that's holding the CON, or that can you oppose a facility, or does it have to be a CON? Am I explaining myself right? Let him explain it.
Well, you can.
No, I think that's, I think the question, we had received some information that some hospital systems had hospital outpatient centers in Baldwin, Bibb, Cherokee, Clayton, Cobb, Dawson, DeKalb, Douglas, Fannin, just a list of counties. And her question, I think, or our question was that, would they be the parties on line 313 because they're a hospital outpatient center? Does that give them the permission to oppose anything in a 35-mile circle, say around or within 35 miles of that hospital outpatient facility in Union County or Hall or Henry? Does that give them standing if they have a hospital outpatient center? Or is it something about it has to be the central CON hospital? So even if they had an LNR, they would still be eligible to object to something. Okay.
Chairman Rogers.
Thank you. Further point of clarification. So if I'm making general and I have a convenient care center only, because as I read this, it says existing health care facility, and I don't know what that actually means in code, but if I have a convenient care facility in 3 counties over, and someone wants to go open up a hospital in that 3rd county, does that convenient care open 9 to 5 or even 24/7 allow them to challenge that competition in that particular area? What line, Ms. Betsy?
55. Line 55. Definition of a health care facility.
Mr. Chairman,
yes.
I believe that the CON laws would you have to be operating a like facility, a like service offered facility. I see what you're asking now previously, so the intent is to do what's that it has to be a like facility. And if we need to clarify that in language, then I am very open to doing that.
I applaud.
You know, if I have a CCRC and somebody wants a hospital, that's not the intent is for that to not object to that.
You're
That's
right.
my
And please
intent.
understand, I applaud if Columbus Regional or a Phoebe or somebody wanted to open up 9 to 5, 7 days a week, a place for someone to go get a prescription for amoxicillin and take care of your basic needs. That's almost micro, and I applaud that. But on the other hand, I don't know if I'd necessarily want that to be the reason why someone couldn't go in there and potentially open up a hospital. That's my point.
Agree.
Or my concern. Thank you, Mr. Chairman.
I can't hear. Can we clarify?
Can we get that? Mhm.
That's why I question the legal standard.
Chairman Houston.
I agree that the main hospital should be able to oppose it in 35 miles, but if you've got a radiology department, or just a radiology center, I don't think in a county far away that you should be able to oppose it for somebody putting a hospital there. I think the main hospital, the ones that holds a CON certificate, should be able to oppose it.
Agree.
And it should be the CON certificate person that could oppose it. But not on the basis of, so, you know.
Ms. Chairman, are you finished? Chairman Houston.
I think if you change it to hospital to healthcare facility, the hospital might do it. Well, it's my understanding that one hospital has outpatient facilities in Baldwin, Bibb, Cherokee, Clayton, Cobb, Dawson, DeKalb, Douglas, Fannin, Lafayette, Forsyth, Fulton, Greene, Gwinnett, Habersham, Hall, Henry, Houston, Paulding, Pickens, Pulaski, Rockdale, Spalding, and Union. And I don't think that one hospital should be able to control filing against the CON in every one of those counties.
Chairman Hatchett. Now, just so everyone will know, you cannot do an amendment to a substitute.
Okay.
The substitute has to be rewritten with the amendment worked into the language. So
Can it be amending rules?
Well, we can amend it. However, when the final draft goes to rules, that amended language has to be in the
Well,
text.
I was just pointing that out,
Right.
that was a concern.
Madam Chair, I'm wondering if the committee would entertain on line 314, unless such party is an existing similar healthcare facility. Is that correct, legal counsel?
Mr. Chair, while that discussion is going on, would I be out of order to get the hospital's opinion on what their intent and how they interpret this is?
Well, what we're trying to do is get the legal definition versus the hospital's definition. Let's see what we come up with here first.
Thank you.
Dr. Newton.
I was just going to suggest, since in the definition section on line 64 of the bill is the current definition of hospital, which does seem to be what Chairman Houston was looking at. If that was the wording, that would give that 35-mile, I did the math, it's 3,800 square miles around for a 35-mile radius circle. That would give that in line 314 if it changed to existing hospital facility located in that 35-mile radius. It would give them kind of that zone of protection dramatically larger than the 300 square miles that you had in your original 10-mile radius. I think it would still protect the hospitals from that unfair competition. I thought that was part of the goal. I think that is our goal. So it would just add the term hospital, which is defined on line 64 in the bill, and it would add it, instead of healthcare facility, would just, it'd be an existing hospital facility.
Betsy, I think, does have some language that would probably answer all of these questions, I think.
Betsy, could you come up to the microphone, please, ma'am? You can either sit at the first or second one. Take your choice.
All right, on line 314, after healthcare facility, if you add for the same type of healthcare facility proposed, or which offers the same type of services proposed, and then you continue on. That would narrow it to if it's in the same category of facility or if it has the same services, and within 35 miles, and they're the only ones that could oppose.
Representative Newton.
I appreciate that. I guess when I look at lines 55 through 61, the definition of healthcare facility, and then the like kind, a lot of places offer maybe some rehab and radiation, x-ray maybe, or some offer some immediate care. That list is so exhaustive on intermediate care, ambulatory surgery, health maintenance, home health, diagnostic treatment. That just seems to be a very broad definition that would probably include that list Chairman Houston said of the 20 or 30 counties that it's a hospital outpatient center. I'm not sure what all goes on in a hospital outpatient center, but I would imagine some diagnostic and treatment and possibly other things go on that would make it, they couldn't offer, if anything was similar, it seemed like that would allow them standing to oppose somebody who, even as a small part of their business, did rehab or diagnostic. I don't know. I think that's where I was getting at, is the goal to give a zone of protection around, in particular, like CON does around rural hospitals, the real hospital itself, not necessarily, because I know they purchase practices and convert them into outpatient centers in a lot of different areas, and that would just be a broad swath of Georgia.
So your recommendation is putting hospital in front of healthcare facility, a hospital healthcare facility.
And instead of healthcare facility, a hospital
Existing
facility.
hospital.
Existing hospital facility.
Yeah, you'll use your microphone, please, sir.
Could you have her to read that definition just one more time?
Yeah.
Sure. Yeah, you want me to read it, how the whole thing would read? Or, okay. Line 313. So the whole thing would read, no party may oppose an application for a certificate of need for a proposed project unless such party is an existing healthcare facility that is the same type of healthcare facility proposed, or which offers the same type of services proposed, that is located within a 35-mile radius of the proposed project. Got that?
Okay, Dr. Newton.
Just looking at it, because of the diagnostic treatment and rehab, the diagnostic, it does seem like that would give a lot of 35-mile radius circles that you certainly couldn't have a freestanding emergency department, because they do a little bit of diagnostic. That would give a lot more people opposition. I don't know how much overlap the similar facility has to be. Could a radiology center oppose?
Yeah, that would be, fleshed out in DCH rules as far as the.
Why couldn't we just say hospital?
I mean, you can certainly say that, but that would then limit any other type of facilities to oppose. So that's up to you all. That means an ASC couldn't oppose, or a rehab center couldn't oppose.
That means ASC cannot oppose another ASC coming right next door.
Right.
Okay, Betsy, start with an existing healthcare facility, then your language.
Okay, the new language would be, that is the same type of healthcare facility proposed, or which offers the same type of services proposed.
That would be done by rules.
What did you say?
What's that?
Betsy said.
This process is already set up by DCH. It would just be minimizing, who could actually oppose. So, I mean, all these, the establishment of the services and that kind of thing is already covered under the rules and the procedures, so. Sure, works for me.
Representative Fry.
Thank you, Mr. Chair. I agree with the doctor. I think it just needs to change the hospital. If the goal is to try to protect the hospitals in rural Georgia, that's what I thought we were looking at, and creating more competition for other.
The problem is if you do it just for a hospital, then, like I mentioned, you can have an ambulatory surgery center right here, and there's nothing to prevent one from coming in right next door to you. Unless the language is like she has in her proposal.
May I ask a question?
Well, why can't we build a hospital right next door to another one then? That's because what we try, yeah, because of the lobbies. So, this is what we're trying to get settled here. Do you have a comment?
Well, and to the Representative Fry, if that was the case, if it's protecting rural hospitals, if you don't say the same thing about LNRs, and you've got a rural hospital that already has an LNR by it, then you could have 2 more LNRs go right by your hospital, which would, in essence, not be good for the small hospital either. So it's good to have it fit both the hospitals and the LNRs. Think about that anybody could open up around that small hospital.
Representative Newton.
Yes, sir. Just if it's the appropriate time, I think that language with substantially in there, substantially similar, I think instead of I think that would be, I would just move that's an appropriate and careful change. I would move we accept that if that's appropriate.
So you're ready to make a motion to approve the language that legal counsel?
Only thing I would add is read the language, but I would probably put substantially similar instead of, or if that's necessary but
okay.
Whatever you think. Could you read it again?
With that language? Yeah.
Sure.
So the new language then would say that is the same type of healthcare facility proposed or which offers substantially similar services proposed.
That is located within a 35-mile radius. Right. Yes. I would move to accept that.
You make that as a motion to?
Yes, sir.
Did I hear a second? Okay, got a move and a second. All in favor for the change or the amendment to the sub, say aye. Aye. All opposed, like sign. Okay, so the new language that is as an amendment would be inserted into the substitute because that's the only way you can do a substitute. So now we've got the substitute for House Bill 198 as amended. Well, I guess we're ready for a motion on that too. You make a motion?
I'll move do pass.
Got to move do pass. I hear a second. All in favor say aye.
Aye.
All opposed like sign. Thank you all.
Thank you.
We can go to session now.